Hello friends, good morning, good afternoon, good evening, depending on whichever part of the world you are in. Hello to everyone, hearty welcome to the 50th session in our Learn from the Legends webinar series. Today to discuss, we have a very interesting problem and I'm sure that we are going to have interesting discussion regarding the same. The field of neuroprotection is changing rapidly with tailored therapies needed to optimize outcome. And to throw more light on the developments happening in this field, we have a true legend in this field, Professor Nicola Robertson. Before I introduce her, I also have the pleasure and the privilege to introduce two of the great doyens of pediatrics and neonatology from India, Professor Nirmala Cheruguri and Professor Bibekananda Mukherjee. Dr. Nirmala Cheruguri is the Professor of Pediatrics, Institute of Child Health, Nilofer Hospital, Osmania Medical College, Hyderabad. She was the president of IAP Telangana State in 2018, executive board member of Central IAP 2013. She has held various official capacities. She was she had done various works and have 18 publications in index journals, co-investigator in vaccine-based clinical trials, and she is a core academician to the core in all aspects. Welcome, ma'am. The second moderator is Dr. Bibekananda Mukherjee. He is a well-known name in Kolkata. He is the Associate Professor of GIMS, Kolkata, with experience in neonatology and resuscitation and 25 years of teaching experience in tertiary neonatal care, NICU. And he also has had various official positions in the state of West Bengal, and he is an invited faculty to Neocon, Pedicon and various other conferences. Welcome, sir. Now I have the pleasure to introduce the legend of the day, Professor Nicola Robertson. Nikki is the Professor of Perinatal Neuroscience at UCL and University of Edinburgh. She has researched neuroprotection and neuroimaging of the term newborn over the last 25 years and has developed preclinical models to assess novel therapies to protect the brain with and without hypothermia. Research is a passion for her, as you will realize from her talk today. She currently runs two preclinical laboratories, and most of the bench studies and animal studies have some reflection there as well. She has researched neuroprotection and neuroimaging of the term newborn over the last 25 years and has developed preclinical models to assess novel therapies to protect the brain with and without hypothermia, as I said. And her research work speaks volumes. She has published over 240 papers and supervised more than 20 PhD graduates. Her life is devoted to this, and her goal is to find therapies relevant to low middle income countries as well as high income settings as well as neuroprotection is concerned. Ladies and gentlemen, let's welcome Professor Nicola Robertson. Over to you, Nikki.
Well, good afternoon, good evening, good morning. It's an enormous pleasure to be here. And I'm very grateful to Dr. Manoj and the team in Kerala for this wonderful invitation. I'm going to talk to you about not just stem cells. I'm going to talk to you about much more, including cooling, which is a very hot topic at the moment. And I watch with enormous envy at the beautiful pictures of Kerala and the warm, beautiful beaches as here in the UK, you probably see behind me, it is snowing, and it is, I think, 0 to 3 degrees. So a very, very warm welcome to you all. And I'm going to, without further ado, move on with the plan of my talk. I'm going to just give an overview of neonatal encephalopathy, the incidence, and the fact that it's an evolving injury, and then focus on the global perspective of high and low income settings, and then look at promising therapies, including stem cells, but also including some of the very, very promising therapies such as melatonin, caffeine, and azithromycin that you may not be aware that we're working on, and then leave you with some ideas of where we might be in 5 years. But I want some participation from you and some of your ideas, and there'll be 2 polls in this talk, and I'm very grateful for your participation. So first, we're going to talk about neonatal encephalopathy. And on the right of the slide, you can see the definition and the epidemiology. First of all, the definition we're all aware of. And the WHO has said that neonatal encephalopathy is one of the 10 leading causes of lost years of life. And you can see the huge inequality across high income and low income settings with different incidences of 0.5 up to 12 per 1,000 live births. There is some good news, however, in European studies due to improving prenatal and perinatal care, that the incidence of neonatal encephalopathy is halving, as you can see in Wales and in the Netherlands. But globally, we are still faced with the fact that over 1 million neonates have injury associated with intrapartum hypoxia, and a huge inequality across centres. And you can see on the left, high income settings, and on the right, sub-Saharan Africa. And you can see South Asia is just behind that. In terms of an increased incidence of neonatal encephalopathy in boys, and the other factor, that infection and inflammation are key risk factors for injury and exacerbate the outcome. So we're left with a situation, on the left, we've got high income settings where we have therapeutic hypothermia, which is standard of care, but yet it isn't the silver bullet. Despite cooling, 20% still develop cerebral palsy, and up to 60% have cognitive impairments at school age. And then on the right, in low and middle income settings, we know that hypoxia may have started many hours before delivery, resuscitation may not be optimal, and there may be other comorbidities such as sepsis. And of course, we're very aware of the Helix trial outcomes and the possibility that cooling may not be as safe in all babies. I'm going to focus on that a little bit later. But here, I want to draw your attention to this excellent review article by Neil Marlowe and colleagues about outcome in neonatal encephalopathy, and taking you through on the left side, showing there's a very, very clear benefit of cooling at 18 to 24 months in high income setting trials. However, in the middle here, you can see that despite cooling, there's still a large unacceptable number of babies who have CP 20%, or cognitive problems around 30%. And then on the right, the more recent data that shows at school age, the benefit of hypothermia is actually quite concerning, because a systematic review has suggested that there's still a large number of cool children who have general cognitive problems, up to 60%. And when you do high detailed imaging of the brain at school age, you can see in those babies who've had encephalopathy who are cooled, their connectivity is reduced, and that is associated with their cognitive problems. So our understanding about birth asphyxia is that it is an evolving problem. And we know from our magnetic resonance spectroscopy studies that have been done serially in babies over the birth and the first sort of 24 to 48 hours, that the situation is that during hypoxia ischemia, during delivery, labor and delivery, there's primary energy failure. At resuscitation, the energy within the brain recovers or pseudo-normalizes. And then if you don't do anything, after around 6 to 8 hours, you'll have a secondary wave of energy failure. And that is also seen when you look at proton MR spectroscopy, looking at your lactate to NAA levels. You see a rise, a reduction at resuscitation, and then an inevitable rise if you don't intervene in that early latent phase. Now, one of the things we know is that the cascade of injury that occurs with this energy failure changes with time, and that oxidative stress and free radical formation are some of the earliest damaging high-level events that then activate the cascade. And this massive outpouring of free radicals after birth and after resuscitation then leads to mitochondrial failure, excitotoxicity, cell death, and subsequently a change to a very, very damaging inflammatory milieu. Subsequently, and this is hours and days later, you then have problems with neuroregeneration and brain repair, which go wrong because you've got too much in the way of cytokine pro-inflammatory signaling, and you haven't got enough growth factors, and your cells are dying. So the point of this slide is that we should be targeting these different phases of events in the cascade of injury with different agents. For example, the early phase should be targeted with melatonin or allopurinol or magnesium or argon, or indeed something like caffeine, and more of that later. And the subsequent stages, when you have this inflammation and poor regeneration, it's things like EPO or stem cells that should be used subsequently. So I'm going to talk about promising therapies, and starting with high income settings, because I think we've got situations within countries where you have hospitals that are similar to high income settings, and in the same country, hospitals that are similar to low and middle income settings. I want to draw your attention to these publications that are excellent, that are just out last year about management of babies with hypothermia and unanswered questions. And I want to give you a summary from those 2 volumes of key updates for looking after babies during cooling. Number 1 is that when you're resuscitating, lung aeration is critical, and delayed cord clamping is still controversial, but there is the theoretical advantage of giving more blood cells, more autologous stem cells to the baby, and also improving the perfusion. So if you are going to do delayed cord clamping, only do it if you're able to support the ventilation. There's an important role in optimizing glucose homeostasis and nutrition. It's important to avoid hypercapnia, hyperventilation, and hyperoxia, and start resus in room air. And these are all factors of the neurocritical care in that very, very vulnerable stage just after birth, in the 24 to 72 hours, when you have this evolving injury that can be exacerbated if you get this basic care wrong. We now know that serial echo is very helpful to manage BP, and that parental involvement in care and holding is important. It's difficult, the sedation aspect, but low-dose morphine probably has the strongest evidence. I used to fluid restrict quite severely, but a recent study, pilot study, has suggested that we should avoid strict fluid restriction and avoid hypoglycemia and tailor fluids to individuals. And lastly, all cooled babies should be considered for EEG monitoring, and raw EEG is necessary to pick up seizures. So that is a sort of filtration of the basic main pointers in 2021-22 of the neurocritical care of babies during cooling. And the team from the Newborn Brain Society have suggested that a care practice bundle should be used. And they've come up with these care practice bundles for neonatal encephalopathy, which are quite nice to have by the bedside. And you can see on the left, you've got all the things you should be thinking of when you have a baby who's undergoing cooling. So you've got the do's, and then you've got the don'ts. So I leave that with you, and if anyone can't access this online, I'm very happy to send you these, and they are quite good to have as a discussion point when you're doing a ward round on a baby with neonatal encephalopathy. But I want to focus now on adjunct therapies, because as I've outlined, cooling by itself is not enough to protect the brain. And so these are ongoing trials as of March 2022. We have the Albino Trial ongoing in Europe, which is early allopurinol plus cooling versus cooling. I was in Germany last week, and I'm told that this trial is it's quite a difficult trial to recruit to, because allopurinol needs to be started within 30 minutes. There's also a trial of sildenafil, which acts on cerebral blood flow, and this is PK and safety. We're awaiting the outcome of Cool Xenon 3, although I would say that the Toby Xenon study was negative. And of course, we are all waiting for the HEAL and the pain trial results of high-dose EPO with cooling versus cooling. And lastly, there are two other trials ongoing with stem cells, which we are awaiting outcomes. And there's also a trial with cannabinoids. So lots of therapies. The therapy I want to talk about, and one that I've been researching for well over 10 years, is melatonin. Melatonin is an endogenous hormone. It is probably the first biological signal in the most primitive of organisms, and is a very, very diverse signal present in plants, and is very, very robust antioxidant. We know that melatonin is produced in the pineal gland, and the activation of melatonin is by darkness, and it is inhibited by light. It is metabolized in the liver, and then it is secreted in the kidneys, but all of its metabolites are also free radical scavenging. Melatonin is secreted mainly at nighttime. It's interesting to know that the Chinese medicines that treat diseases of age, which are associated with high free radicals, have very high levels of melatonin in them. And if we look at our own melatonin, our physiological levels of melatonin, you can see in the plasma, our melatonin levels are highest around 4 a.m. We also know that when you get to your 40s and 50s, that peak 4 a.m. melatonin is much less than when you were a teenager, which may explain why our teenagers all sleep for so long. Melatonin is vitally important for fetal development. And we know that a mother's melatonin at 4 a.m. is much higher because of placental triggers for the pineal gland to secrete more melatonin. Melatonin crosses the placenta and acts on the embryo fetus by improving circadian rhythm, cell proliferation, free radical protection, and it also has an effect on parturition time. How high are our melatonin levels in our preterm and term infants? Well, they're actually very, very low, because when a baby is born, that melatonin source from the mother is cut off. And it isn't until 3 months or so that babies start to engender their own circadian rhythm and their peak levels of melatonin. What this graph shows from 209 infants between 25 and 40 weeks is that melatonin is below a detectable level of 7 picograms per mil in over 50% of babies, and that melatonin tends to increase with gestational age. We also know that melatonin metabolism is not changed with hypothermia. But what I'm talking about in terms of melatonin neuroprotection is not the physiological levels, but pharmacological levels, 10,000 times higher than physiological levels. And when you get to that sort of level of melatonin, it has amazing effects on free radical scavenging, anti-apoptotic effects, anti-inflammatory effects, and also working on gene regulation. One of the most important things melatonin does is that it is concentrated actively in the mitochondria, where it acts on the electron transport chain and improves the generation of ATP. Of course, this is what we need for our cells to survive. And it stops your cell from dying. So these are the preclinical studies we've been working on, spanning 2013 to 2020. And basically, we've been looking at the safety and efficacy and pharmacokinetics of melatonin and trying to work out which is the best formulation and route of administration to use for babies. We've done this in large animal model, the piglet, and we are now at a stage together with the team in Australia, who've also worked on the newborn lamb model, where we feel we're ready to hopefully go into early phase clinical trial. One of the things we've just done is put together all the preclinical studies into a systematic review and meta-analysis, together 14 studies of over 100 animals, looking at the question is, does melatonin improve or reduce brain injury? And you can see here on systematic review, melatonin reduces brain infarct, it improves neurobehavioral outcome, and it reduces cell death. We've just had this paper accepted for publication. We also can see that melatonin is effective in normothermic conditions, and it also augments hypothermia. And an interesting observation, but very important from a practical point of view, is that melatonin formulations containing ethanol, a tiny amount of ethanol, as does many therapies that we give to babies on the NICU, those formulations contain a small amount of ethanol are more protective than those that don't. So I've been working on this, and this is a review that my PhD student, Ray Pang, wrote to sort of suggest that we're in a situation now where we need to develop an intravenous formulation of melatonin because it is so lipophilic. And we've come to the point where we know that the optimal protection from melatonin is dose dependent. We need plasma levels of 15 to 30 milligrams per liter. So that's 10,000 times higher than our physiological levels. And to get this, we need to be giving around 20 milligrams per kilo of melatonin at 2 to 3 hours, and to give it every 24 hours. The earlier you can give melatonin, the better the protection. We also know that from the pharmacokinetics, this is the therapeutic range between 15 and 30 milligrams per liter. And you can see in the green, in the emerald green, that by giving 20 milligrams at 2 hours after birth, we can achieve therapeutic levels very rapidly. Together with Kieran Moore and Dr. Ahmed, we did a systematic review of the small clinical trials of melatonin that have been done in small groups of babies. For example, 10 term babies here, 30 babies in Egypt, and another one in Pakistan where 80 babies were looked at. These are good studies, but they're not large enough to really be powered to show beneficial effects of melatonin. And indeed, in the study that was done by Javed Ahmed and Kieran Moore, there was a very low grade of evidence, and the meta-analysis was not conclusive. So what we are trying to do in the UK now is to run what's called the Acumen study, which is a study which stands for Acute High-Dose Melatonin for Encephalopathy of the Newborn. And we're looking at the first question compared to hypothermia alone in babies with moderate to severe encephalopathy. Hypothermia plus melatonin preserves the cerebral metabolism on MR spectroscopy on postnatal day 5 to 15. And this is so that we can get a very early outcome pointer of whether melatonin works. Of course, we're looking at secondary outcome measures, such as neurological outcome, EEG, seizure burden, and follow up to 2 years on Bailey-4, FITC, QChat, and of course, probably onto school age if we can get funding. So that's a study we're hoping to run in high resource settings. And I also want to talk to you about mesenchymal stem cells before moving on to LMICs. So stem cells are probably one of the biggest paradigm shifts in the treatment of neonatal encephalopathy. How do stem cells work? They attenuate neuroinflammation, they secrete growth factors, but by far the most important way that stem cells work is through paracrine secretion of these exosomes that contain all these wonderful growth factors, anti-inflammatory, and important packages of cargo to help cells survive. We also know that stem cells migrate to the site of injury, and so they are active therapies that are tailored to the site and the severity of injury. So just a little aside on these extracellular vesicles, some people are using just the vesicles as a therapy, and they do have advantages over cell therapy because they aren't self-replicating, they can be characterized, they can be sterilized, and they don't change their function in a context-dependent manner, which you will see as quite an important aspect when I come to some of the drawbacks of stem cells. So there's been a lot of work on stem cells, and we are tremendously excited about them as one of the potential therapies that could be given. I wanted to share this paper because I think it's fascinating to see how the stem cells might be working. We know they're working on reducing cytokines, increasing growth factors, and secreting exosomes, and stimulating endogenous cells. But one neat way that they work is by channeling these really healthy mitochondria from the healthy stem cell to the dead and dying cells. And by doing these, by setting up these tunneling nanotubules, these stem cells are channeling their mitochondria to these gasping and dying cells and giving them a regeneration in life, restoring their bioenergetics, changing their metabolism from glycolysis to oxidative phosphorylation, and giving them a chance to live. So this is one very nice way that stem cells are working. How do we give our stem cells? We have been giving our cells intranasally, and we know that cells can migrate through the olfactory route and through the trigeminal route and are attracted to parts of the brain. And this shows very beautifully that if you fluorescent label the stem cells, within 1 hour, you can see the stem cells in the brain tissue, in the thalamus, in the hippocampus, and in the cortex. And all these arrows are showing the fluorescent from the stem cells that have migrated. So many studies have been done of stem cells in preclinical models of hypoxia ischemia, and I summarize them in a couple of slides here. The Dutch group did some work between 2013 and 15 and showed that intranasally administered stem cells promote a regenerative niche for repair. And you can see this Rice-Vanucci model of hypoxia ischemia and vehicle compared to hypoxia ischemia and stem cells. Pretty perfect in terms of regeneration and repair. And you can see with fluorescence that most of the cells are seen at around 12 hours after intranasal administration. The group in Korea then asked the question whether stem cells, acute stem cell therapy given before cooling would augment protection. And that was in another rodent model, P7 rodents, where they, on the bottom panel, they looked at the extent of injury before giving the stem cells, and you can see the cooling plus stem cells led to a marked reduction in injury compared to no cooling or no stem cells. So that is stem cells given before cooling. They also asked the question, well, do stem cells work if you give it after cooling? And indeed, stem cells did work if it was given after cooling. And you can see this here is a combined therapy, and you can see that the level of injury in combined therapy is much less than no therapy at all. So we were all very excited until this paper came along, which was a paper where stem cells were given to P9 mice. And this was after 4 hours of cooling, and then 3 days later, the stem cells were given. This was a most surprising result. What it showed is that combined treatment of hypothermia and stem cells reversed the individual beneficial effects, that you saw worse injury, higher pro-inflammatory cytokines, lower anti-inflammatory cytokines, and reduced growth factors. So why might this be? It seems to be that mesenchymal stem cells will react according to the inflammatory milieu into which they are put. So if you already have an anti-inflammatory milieu and you place your stem cells in there, you will make the brain pro-inflammatory. And the reverse is also true. If you have a pro-inflammatory milieu, as you have just after hypoxia ischemia, and you give your stem cells, you will deactivate that damaging inflammatory milieu. So timing of stem cell administration is absolutely vital. There's a long way to go before we can optimize our stem cell therapy. We need to know the optimal source, the optimal route, the optimal timing, the optimal dose, and whether we need to precondition the cells. For example, this paper, preconditioning cells with thrombin, improved the function of the stem cells. So whilst it's really exciting, there's a long way to go. But I wanted to share with you some work we've done with human umbilical cord stem cells as an adjunct therapy in the piglet model. And this was published last year. We compared after surgery and baseline data and hypoxia ischemia, hypothermia, or hypothermia plus intravenous stem cells given at 24 and 48 hours, both 30 million cells, or hypothermia and intranasal stem cells. And in our study, we use EEG throughout. So EEG recovery is a very important outcome marker. And we also use MRS at 30 and 55 hours. Our data on the EEG showed that if you have intranasal stem cells, your EEG recovers more quickly. If you have intranasal stem cells and cooling, your phosphorus MR spectroscopy recovers more quickly, and you have better energy metabolism. And although this is a small study, we showed that we reduced dramatically the cell death in the white matter and improved the oligodendrocyte survival in the white matter with intranasal stem cells. So we are now running in the Edinburgh lab the INSTINCT study, which stands for intranasal stem cells to improve outcomes in neonatal encephalopathy. We're halfway through this study, and it's a study that we hope is going to then lead to phase 1 and phase 2 clinical trials. This is our piglet intensive care unit, where we have a Lami's MR compatible incubator, we have a ventilator, we have EEG, we have NIRS, and we have our intensive care pumps. And this is taking the incubator to the 3T magnet. One of the exciting things we're doing is doing some cell tracking using stem cells labeled with perfluorocarbons, because we need to know exactly where these cells are going. So I move on to the very interesting ongoing discussion about neuroprotection in LMICs. So
I hate to interrupt, Professor Nikki. Do you want me to run the polls here, or?
I'm going to come up. I'm going to ask you very soon to run the poll, if that's okay.
Fine.
So around 10, 15 years ago, I did some work in sub-Saharan Africa, and this is well before cooling was known to be standard of care in high-income settings. And at that time, we were looking at the feasibility of cooling in a low-income setting, and we used these water bottles. And this was very early days, but one of the concerning things we saw, and this was a small feasibility study, was that there were more deaths in the cooled arm, but it probably could have been explained because there were more sun at stage 3s in the cooled arm. However, this was taken up by the research community, and you can see the forest plots here of high-income settings. Or the benefit of hypothermia is very, very clear, and this is a meta-analysis that was done by Thiel et al. Looking at LMICs, and the benefit is slightly less clear. Following that, the group, the Helix trial group, went on and did this study, this large study, which I'm sure you're all very aware of, where they looked at 408 eligible infants randomized to hypothermia or control. They used servo control device for the cooling, and all sites had facilities for invasive ventilation, cardiovascular support, and access to 3T and spectroscopy. So, as we all know, the Helix trial showed no benefit from therapeutic hypothermia. We also know, if you look and drill down on the type of injury, most infants had white matter injury, suggesting perhaps intermittent hypoxia. And 90% had seizures at a very early stage, at around 2 to 2 hours, indicating an early start of injury. I just say that we can't exclude chorioamnionitis, as only the cord was examined for phonocytis. So the author's interpretation was that therapeutic hypothermia should not be offered as treatment for neonatal encephalopathy and LMICs, even when tertiary neonatal intensive care facilities are available. I think this caused a great deal of consternation and worry amongst us all. I draw you to this paper, which I found really useful and quite constructive to understand. And Alistair Gunn and his team asked 2 important questions. Why was hypothermia not beneficial in this setting, despite a high level of intensive care? And how can we reduce the injury in such babies? Well, he suggested that actually the findings were not that different to the CoolCap study, where hypothermia benefit was associated with weight, where hypothermia was associated with greater reduction in adverse outcomes in the top 25th percentile than the bottom 25th percentile. And so hypothermia was more beneficial in larger infants, more likely to have acute complications during labor than smaller infants, more likely to have repetitive hypoxic insults in labor. He also suggests that because of the very early seizures, the high burden of white matter injury, these data suggest infants with lower birth weight have an injury that evolves over the course of labor before birth. And what he suggests is that rather than abandoning hypothermia, perhaps it's important to target larger infants who have had an acute sentinel event and not smaller infants who've had prolonged or repetitive insults. And also to think about earlier cooling or earlier therapies. I'd be interested to know your thoughts on this, but in the meantime, we've been working very closely with the Gates Foundation on single therapies for LMICs, with the idea that in some situations, cooling may not be advisable. And so I come to the first poll, which I'd like you to take part of in Dr. Manoj, if possible. How confident are you about the efficacy of therapeutic hypothermia? And the second question is, have you stopped therapeutic hypothermia in your institution since the Helix study results?
I've just learned, after this is over, I'll just learn that question.
Okay, right. Great, okay.
The second question.
So this one is, have you stopped therapeutic hypothermia in your institution?
Professor Nikki, this probably is the sentiments of the scientific community, what you're seeing here. Shall I stop? End the poll?
Yep. I didn't see the results. Okay. No. Okay. That's great. That's really, really good to see. Thank you. I hope you can hear me. There's terrible hail and a storm going on. And yeah, I apologize. The weather's terrible here. I want to talk to you about single agent therapies for LMIC, because I think this is where we are heading. And even if you are still doing cooling, it isn't enough. One of the agents that we're very interested in is azithromycin. Azithromycin is a generally safe, widely used antibiotic with intrinsic anti-inflammatory properties. It accumulates in brain tissue. And we're already very aware of azithromycin's safety in preterm infants seen in studies of ureaplasma. So how does azithromycin work? It is actively accumulates in the microglia, and it changes your activated microglia from this nasty sort of M1 damaging phenotype where you have nasty free radicals and damaging TNF-alpha being secreted to something that is an M2 phenotype, where this is much more reparative and regenerative. So John Barks has done a lot of work with azithromycin in his preclinical model, and he's shown that azithromycin treatment improved outcome and reduced brain injury. Treatment was more effective with higher treatment levels and earlier onset. So treating at 1 hour was better than 2 hours, was better than 4 hours. And we also know that azithromycin improves outcome in neonatal and adult stroke models. So azithromycin is clearly something that we're interested in, given that abnormal neuroinflammation is a key part of the damaging process. This is a scheme of our preclinical model where we randomize our animal after LPS sensitization and hypoxia ischemia to vehicle, melatonin, or azithromycin. And here we gave, I think it's 20 milligrams per kilo at 2 hours, 24 hours, and 48 hours. And again, we look at our MR spectroscopy, our EEG, and our histology. And basically, on the MR spectroscopy, we saw on Bayesian statistics a very high probability of improvement in your lactate to NAA in the basal ganglia with azithromycin. We also saw, and this was late on, at 55 to 60 hours, an improvement in the AEG recovery with azithromycin. And just to say that in none of these animals was cooling going on. So we are continuing with this work to finish the numbers up to the full quota to see if azithromycin is something that could be taken into early phase clinical trials of babies. The other agent that we're very attracted to is caffeine. Caffeine is widely used, methylxanthine, used in the 1970s as a treatment for apnea of prematurity. And we all know that the CAP trial showed improvement in neurodevelopmental outcome at 18 months with a 2-fold reduction in CP. How is caffeine working? It reduces inflammatory cytokine release, it's antioxidant, it is an adenosine receptor antagonist, and reduces intracellular calcium. So the neuroprotective effect in infants with encephalopathy is unknown. The preclinical studies in rodents are very promising, where single dose in P10 rodents reduced inflammation. It restores background EEG recovery and reduced tunnel cell death in the hippocampus. So we're looking at caffeine as a neuroprotective intervention in chronic hypoxia ischemia. Again, here we have randomized control, low dose caffeine, which is what we give in the neonatal unit for our babies for treatment of apnea, or a high dose caffeine, which is 60 milligrams per kilo, 60, 30, 30. So we haven't got the results for that. I hope I can talk to you about the results sometime in the future. I think now I come to what the final few slides and how are we going to optimize neuroprotection. And basically we need a cocktail of interventions that are tailored to the setting and are dependent on the time after birth. And I summarize here the main contenders are EPO. Again, we know EPO modulates inflammation, angiogenesis, neurogenesis, promotes white matter development. There are clinical trials we're awaiting the results of. There is an issue that it doesn't cross the blood-brain barrier, and there's a U-shaped response curve according to dose. And recent sheep studies suggest no benefit of combined EPO with cooling after hypoxia ischemia. Melatonin, as I've told you about, it's a safe agent, it does cross the blood-brain barrier, and it has diverse properties, and mesenchymal stromal cells that have a huge power to improve outcomes, but timing is everything. And so I come to the second poll, which I would be really interested to hear about. What is the next therapy, in your opinion, to be tested as a single therapy? Is it EPO, allopurinol, melatonin, stem cells, cannabinoids, azithromycin, or caffeine?
Here we go. All right, here are the results.
Ah, stem cells.
We have come prepared to hear stem cells. Here's the next
And
question. Yeah.
how soon after birth would you be able to get consent and start intravenous infusion?
Yes. Here are the results.
Oh, wow.
Things are not as bad as, or rather,
That's amazing. I mean, okay, that's great. Fantastic. How about, well, let's come to it. It's so fascinating. I'm going to move on to the final few slides. So I promised I would give my ideas, and I'd be really welcome to hear your ideas on where are we going to be in 5 years. Given the context of the evolving injury with excitotoxicity, oxidative stress, inflammation, mitochondrial dysfunction that is evolving, where I think we are going to be, we're going to have an acute care bundle. We're going to optimize our basic neurocritical care of babies undergoing cooling. We're going to be neuromonitoring. We're going to be treating seizures and giving hypothermia. But we need an early adjunct therapy, such as melatonin. In the subsequent phase, in the tertiary phase, once cooling has finished, and we're in this situation where we've got dysregulated inflammation and still cell death, we need our neuroplasticity bundles, which include optimal nutrition, music therapy, good sleep-wake cycling, but probably we need later therapies such as stem cells or EPO. So basically taking a couple of the therapies, and then in LMICs, acute care bundle and potentially targeted hypothermia. And you know your units better, of course, than people in high income settings. So you will know whether you are going to continue with your hypothermia. But in addition, there need to be adjunct therapies started as early as possible, or antenatal administration. But the top ones and the safest ones, I think, are melatonin, azithromycin, and caffeine. The thing about stem cells is that it's difficult to store them, transport them. They're kept at minus 150. They need to be thawed down to minus 80. It's coming, but it's probably not the first thing that will be available. So I think that's it. Thank you so much for listening and participating. And I hope there's some discussion. Thank you.
wow, that was truly amazing. Very interesting lecture. Everybody should agree with, and I'm sure everybody will agree with me. It was very extensive coverage of hypothermia plus and all the concepts and which have been covered. Now we have an interesting panel discussion coming up. The question answers will be moderated by Dr. Nirmala Churukuri and Dr. Vivekananda Mukherjee. But before I call upon them, we have another doyen who has done some original research. I am not sure whether he is able to hear us. Professor Subair Gai. Sir, are you there? Do you want to make any comments? We are aware that you have done some original stem cell work, especially with the milking issue. I'm not sure if you are able to hear us.
Yeah, I am here and I can hear you. And, it was really a nice presentation and we really need some therapy for neonatal encephalopathy, especially in the low and middle income countries. We are kind of doing stem cell transplant by doing umbilical cord milking. We're starting a clinical trial actually next month in India involving 65,000 deliveries at 7 centers and probably more than 1,000 babies with moderate to severe HIE. So I know there's many ways of giving stem cells, and one of the way you can do is by doing umbilical cord milking. There was a trial just completed in USA by Anup Katheria. It's a big trial. I think he's going to present his data at PA's meeting, and he has shown umbilical cord milking in a depressed baby decreases the NICU admission. I'm not taking away any of his secret because he's going to present it at a PAS, but it is a safe in a baby who are depressed at birth. And it has some positive effect on a babies with neonatal encephalopathy. So hopefully we're going to complete our trial in a year or so and we will have data. But one of the way of delivering a stem cells to the baby immediately after birth is by doing umbilical cord milking. The amount of stem cells they get it by umbilical cord milking is almost similar to what they have tried. They have tried at Duke's, giving us stem cells after the in a baby with HIV.
Thank you so much, Professor Subair Agai. And Professor Nikki, you want to make any comments before we start the panel discussion?
No, just that's fascinating and wonderful work. I think I look forward to hearing the presentation at PAS. But yeah, I mean I think it's you're going to need a multi-pronged approach. You're going to need several things to help these babies, but that's a really important part of the therapy.
Thank you. Now, may I request two of the distinguished moderators who are going to handle the question answers. I know there is a volley of questions. Let's see how you are going to fit in all the questions in the short time we have. Over to Dr. Nirmala and Dr. Vivekananda.
First of all, Madam, I want to really mesmerized by your talks, and it was covered the full gamut of the way the things are going on in this area. And first of all, the INAP target that has been taken to bring down the neonatal mortality in India below at least to a single digit. So based on that, we have concentrated on targeting the primary energy failure areas. But now with the more understanding and the translational studies and inner mechanism of the injury and the role of modulation, immunomodulation and cytotoxic effects, concentration is now going to the areas of the secondary, how to prevent and delay and decrease the secondary and the tertiary areas of the injury. That is now the focus is going on. And I hope the Helix trial has created something very interesting, because if it had been very much effective, then all our concentrations would have gone to that area. Now, once with that type of results, now our concentration is going on to the various gamut of ways we can control these types of problems. And if you really see to the mechanism in which the damage is going on, there are multiple areas, and I won't be unhappy if Madam would have mentioned even another area like remote ischemic post conditioning, as well as the role of and the endocannabinoids role, and so many gangliosides roles. So these are the areas that has opened up, and only deep transitional studies can really help us with finding out the way which will really be practical, useful in our area, especially in the type of countries that we live in worldwide. So we are looking forward to various trials that are already being going on, and even the McCool trial, the HEAL trial, the hypothermia plus trials, all these going on will be giving us much more understanding and bigger trials. There are certain very interesting questions that has come up, and I will request Dr. Namrata to please start with the questions, and I will follow. Dr. Nirmala, please, to please start with the questions, and I will follow her with further questions. Dr. Nirmala, madam, please.
Yeah. Thank you, Dr. Mukherjee, sir. So we have, that was a excellent presentation wherein what all the trials going on with various effects on neuroprotection. So to start with, Dr. Thomas John has asked about HAT is considered as low dose morphine, term versus late preterm. For how many days to be used in a ventilated baby?
Low dose morphine. I think I mentioned that as part of the sedation, and it's a much discussed topic because we need to balance the risks and the benefits of morphine. But the publication that I mentioned come down on the most evidence is for low dose for as short a period as possible, and to use non-pharmacological ways of sedation such as sucrose and holding if you can. And the low dose is I think 5 mics per kilo per hour, so it's the shortest possible time. But I think what we don't want are babies who are unsettled and distressed.
Yeah. There was any evidence by Abhishek Paul, his inquiring if there is any evidence regarding role of antenatal use of caffeine, allopurinol, and melatonin in neonatal encephalopathy, or any further studies are needed.
So antenatal use, there isn't sufficient evidence. I think that there have been some studies, preclinical studies looking at antenatal use of allopurinol. But the study ongoing in Europe, the Albino study, is now postnatal administration, and they're finding it very difficult. We are looking into the possibility of giving mothers melatonin. So getting a preclinical model of that. Melatonin is incredibly safe and crosses the placenta. But I don't think there's sufficient safety and efficacy data for us to move into any clinical trial yet. I also noted that there's a couple of questions in the chat asking about the whether enteral melatonin might be possible to be used. And I really don't think so, because as I said, we need to have 15 to 30 milligrams per liter for optimal protection. So we very much need to have an intravenous formulation that is given as quickly as possible, rather than relying on the uncertain bioavailability of gastric absorption. So I think that's why we've spent time working up an intravenous formulation, which is now going to be ready soon.
In the same relationship, any relationship between melatonin and sepsis in preterm babies? This is by Dr. Das from Kolkata.
Not that I'm aware of. It's just that the melatonin is incredibly low in preterm babies. But I don't think there's any relationship between melatonin and sepsis.
Mukherjee, sir.
Yeah, there is another question related to melatonin. It seems that several of the melatonin studies use enteral melatonin.
Yeah, that
So
is
we have
covered,
already,
sir.
so we have already dealt with that.
Yeah.
So there is another question from Dr. Bahari. In LMIC, where IV caffeine is not available, is aminophyllins a reasonable alternative?
So that's a difficult one. I think number one, we haven't worked out the optimal dose and whether caffeine is efficacious in a large animal model yet. The data will be available within a year. And it's difficult to just extrapolate from one drug in a class to another drug in the same class. I wouldn't want to extrapolate. But I think let's just wait and see. And I think we can't assume that it would be as protective or safe.
Here's asked another question of EPO was studied to modify IVH 3 to 4 outcomes in PREMS, but results were not encouraging and RCT was done. His comment on that. Yes,
so you're probably alluding to the Peanut trial as well, where EPO was given to the preterm, and there was no benefit in terms of neurodevelopment or benefit on the cytokine profile. So I think that all took us by surprise. And I think EPO has huge possibilities, but what we've seen in the lab is how its benefit seems to be related to the timing of its administration. When it was given early on with melatonin, we actually saw a worse outcome than when melatonin was given by itself. And I think timing is everything. We need to focus on the phases of injury and perhaps think about EPO as something later on. Other people have found that early EPO can increase the inflammatory profile, which is worrying. So we do need to go back to some of the preclinical models and work out the timing before really making sweeping statements about what to do in term babies.
Dr. Aditi De has raised an issue regarding the HELIX trial. You have already covered some of these points while discussing on HELIX trial. She is telling that the ineffective results of the cooling is more so related to the poor resources in the antenatal care and postnatal resuscitation at the referring birth hospitals. Therefore, shouldn't the focus be on improving neonatal resuscitation practices than halting therapeutic hypothermia? But what I feel is that not only the hypothermia has a role on the early injury, but it has an important role in the later injury. Your comment, madam.
Yes, I think hypothermia has a long-lasting effect, but by changing the trajectory of the early injury, it's going to have a huge effect on the subsequent injury. So, yes, I think cooling is here to stay and has been in most of our hospitals and has been remarkably safe. It's perhaps not that surprising that it wasn't seen to be as effective, in that I think the mean age of starting cooling was 4 hours, but the babies 90% of the babies were fitting by 2 hours. And we know from preclinical studies, if you start cooling after the initiation of seizures, it's going to be less effective. So what we're faced with is much earlier treatment and probably increasing our battery of therapies over and above just cooling.
Dr. Nirmala, please.
Yeah. Regarding the role of stem cells, the effect of stem cells in neonatal sepsis, whether it will be anti or pro-inflammatory, which you had already covered, but a clarification, and what is the procedure of administration of nasal administration of the stem cells? So Dr. Surender Bisht and Dr. Blanca Artiga had asked these.
Okay, so the stem cells, if I start with the administration, so we administer first hyaluronidase to clean the nose, and then we inject, I think it's 30 million cells that is in 1.5 mils up each nostril, and it's remarkable. There's very little discharge from the nose. They seem to be absorbed. We keep the head up, and they within 12 hours have migrated predominantly into the brain, and we can detect them very clearly. In terms of the use of stem cells in sepsis, I'm not sure about all the studies and the effect of that. I don't think there's enough known. I mean, I think the studies that I presented were all around an acute hypoxic injury. We have not looked at stem cells in an LPS sensitized injury or chronic hypoxic injury, and that's probably something we will do in the future.
Dr. Arup Roy inquires about, are there any bioethical issues in the stem cell therapy?
Well, I think we haven't come across any. We are using human umbilical cord stem cells, and these are GMP. They are accepted by the MHRA for human use. And one of the big hurdles that we will have before getting this into clinical trials is to be sure of the safety. So we're doing a long-term efficacy outcome model in the piglet, and also where the cells go. That's why we're doing the cell tracking. But I think stem cell therapy is very much actually accepted in many parts and for many diseases, and especially the MSCs that have a low immunogenicity and are not actually engrafting themselves. They are just acting through a paracrine effect.
Yeah, over to you, sir. Yeah.
You have to unmute yourself. You're muted.
Sorry. Yeah. So is there any role for magnesium sulfate?
Yes, I mean, I talked for long enough. I could have talked about magnesium sulfate, and I certainly could have talked about remote ischemic post-conditioning, but there wasn't long enough. You have to invite me again.
Yeah.
So magnesium sulfate, we've looked at magnesium sulfate, and in the preclinical model, we've also seen there are clinical trials of magnesium. In our preclinical model, we looked at a bolus of magnesium and then a constant infusion to try and double the magnesium levels. And we did see a benefit in terms of our MRS and in terms of the white matter cell death with magnesium, but the benefit was mild. And I think my takeaway message is that we should optimize magnesium levels in our babies as much as possible, but I'm not sure that magnesium itself per se is going to lead to remarkable improvements by itself as an adjunct. So let's optimize magnesium levels, and I think I'm going to keep that as something on my last slide, is that babies need to have high levels of magnesium.
There are a few questions regarding, again, nasal administration of stem cells. How to administer nasal?
Yeah, that is covered, sir.
That is covered.
Yeah.
Okay, then Dr. Das has asked another question: role of melatonin in non-HIE neonates conversion or in neonatal encephalopathy.
I'm sorry, role of melatonin in
non-HIE neonatal conversion. neonatal convulsions without having hypoxic ischemic encephalopathy.
Okay.
Or
So
in neonatal, sorry to interrupt. Neonatal epileptic encephalopathy.
I'm not aware of melatonin being a very robust anti-epileptic drug. It does have some effects against seizures, but it's not something that I would use acutely in seizures. It is used in children who have cerebral palsy to help their sleep-wake cycling, so that they have a good sleep and they get into a rhythm. Because I think part of the brain injury that occurs following HIE is a disrupted diurnal variation in the melatonin. But I wouldn't advise using melatonin in these non-HIE epilepsies.
Even he has asked regarding role in meningitis sequelae.
For
Melatonin. Yes.
I mean, that's interesting. I think in many ways, melatonin is very low in sick babies. It's very low in babies, and it's much lower in sick babies. And there is an argument, perhaps, to be thinking about melatonin as an antioxidant in these babies. You may well be alluding to some of the small trials that have been done in Italy, looking at the use of melatonin in septic babies and surgical babies and BPD babies, but these are very small studies and we cannot really take anything from them, I feel. We need to ask robust questions with large enough group sizes to really decide whether melatonin is an effective therapy. So these are all diseases that have high levels of free radicals, but there's no evidence of the use of melatonin in them.
Thank you, Madam. Dr. Nirmala.
There is quite interesting one from Dr. Livert Mamani Flores regarding your opinion on cholesterol therapy for neuroprotection.
I think it's very exciting, the area of cholesterol therapy. We're not there yet. We are thinking about starting some preclinical studies, but we're, watch this space really.
And Dr. Murliraj inquires about the Azithromycin trial and the 20 mg per kg to be given whether IV or oral, which is better.
Well, we're giving it IV. I mean, we're still waiting. We still need to do another 2 months of studies and then we'll have a result. We give it IV, but it's not a positive outcome yet. Although it's looking that way. If you believe in Bayesian statistics, it's very much looking that way.
Yeah. Dr. Veronica Mendoza inquires about the use of calostrum intranasal as a source of stem cells.
Yeah, that's a very interesting question, and one that I get asked almost every time. I think there's a group in Germany, in Cologne, that are using maternal fresh breast milk intranasally in preterm babies with the aim to improve IVH. There are a lot of stem cells in colostrum, but I'm not sure that there's 30 million stem cells in 1.5 mils. So the response is related to dose, and I think we need to have more studies. It's perhaps something that we need to do in the lab, is to get some colostrum and to track it and see how many cells are in there.
Yeah. Such an interesting session. with various newer modalities of neuroprotection in the newborns. Over to you, Manoj, sir.
Thank you so much, madam.
Thank you, ma'am.
Thank you, Dr. Bibekananda and Dr. Nirmala, for moderating a very difficult, compressing all the questions and then asking. You've done very well. And I really would like to thank the faculty for the day, the legend for the day, Professor Nicola Robertson. Nikki, you had actually, ignited lot of queries in the minds of people, and then the lot of queries. I am aware that some of the queries won't remain. Will still remain unanswered, but that's the way science is. And it was wonderful to have you here. Your life is totally devoted to research, as we all know. So we would really look forward to more and more contribution from you. And then it is so nice of you today, being a very busy day for you, still having devoted all the time for us. So from all of us here, thank you so much, Professor Nicola Robertson.
Thank you. It's
Thank you.
great to participate.
Thank you so much. And today was the 50th session in our series, but we are not done yet. We continue, and then we have in the month of April, we have 2 sessions coming up. I'm sure the details have been already published. You must be aware of it. The first one is on 14th of April. That is on evidence-based neonatal care, role of care bundles in NICU by Professor Arun Nair from Auckland University, New Zealand. And the second one is on 28th of April by the legend of all times, Professor Martin Kessler, on volume targeted ventilation. One size does not suit all. So please continue to join. We continue in the and I would like to thank all of you for having joined us today, and see you until next time. Bye bye.
Thank you for the invite, sir. Thank you.
Thank you so much.
Good night.